Okay, well, good afternoon. Thank you for joining us this evening. Welcome to the Health Center's Interventions Against Reemerging Infectious Diseases, hosted by the National Center for Health and Public Housing. At NCHPH, our mission is to, uh, strengthen the capacity of federally funded public housing primary health care centers and other healthcare grantees by providing training and technical assistance. Reminder that the content of this webinar is financed by HRSA, but does not represent the official views of HRSA, HHS, or the US government. My name is Jumaka Oladipo. I am the Health Communications and Research Analyst at NCHPH, and we will be hearing from Dr. Kevin Lombardi, who is the Manager of Policy, Research, and Health Promotion. And we're also joined today by our colleague, Chantel Murray, who is the Manager of Communications. A few housekeeping rules before we move on. A reminder that all participants are muted upon entry, so please make sure to engage in the chat or raise your hand if you would like your line to be unmuted. This webinar is being recorded, and the slides and recording link will be sent via email shortly after today's session. We'd also like to know more about you, so please put your name, your title, and where you're joining us from in the chat. Without further ado, here's Dr. Kevin Lombardi.
Hi, everyone. Welcome. And this is going to be the screen for a little while before we get into it. Firstly, for all of you, please put where you're from in the chat. This is so important for me. I want to know a little bit about you, who you serve, and how you serve them. That's going to help us to adapt this material to you today. And also to thank all of you for your service to the public. You are the walls that keep us safe, the FQHCs, the PHPCs, and their allies. Thank you for what you do for our citizens of our country and for joining us today. So let's get right into it. And let's see what we have here. Oh, fabulous, guys. Keep putting them in there, please. Thank you. My name's Dr. Kevin Lombardi. My background is as a physician, internal medicine, and as an epidemiologist. I started at, and I'm going to go through why I know what I'm telling you today and sort of where we are as far as the material and adapting it to all of you at the health centers. My education was at GW, both my MD and my MPH. And GW and DC is a really unique place to learn about infectious disease. And the reason is, one, the climate. Because we are geographically in the American South, there's a long history of tropical disease management in DC. DC used to have active cholera outbreaks, and malaria would climb up during the summer. Now, this is a condition that's no longer in the contiguous United States, but 150 years ago, there were cases of malaria at GW Hospital. Why don't we have malaria anymore? Why don't we have cholera anymore in GW? Why didn't I see that when I was in my training? And that's because of the public health efforts that we have done collectively as a country over the last 150 years. We've made our cities safer. We have made the water cleaner. We have increased the power and the reach of our primary care centers and our emergency rooms so that all of us fulfill a very important role in building that castle that surrounds us and protects us from infectious disease. The reason we don't deal with cholera at GW anymore is because of those things. Things like sewer systems, drainage systems, health centers, nurses, and community health workers. That's all of you guys. And I want to illustrate just how important that role is. We are all practicing infectious disease prevention every day. Every day. Who washed their hands today? Who made sure they weren't sick before they went to work? Just before you get in the door, you do something to protect your colleagues and protect your patients. When you're there, your protocols, cleaning instruments, scrubbing in and out, wearing masks, informing patients about vaccines. These are the things you do that protects the public. You are part of the infrastructure. Your awareness is another important part of that infrastructure. How do we know when the first case of measles shows up in a metropolitan area? Well, we know because someone identified it. And these conditions, malaria, measles, mumps, rubella, respiratory infections, they all have signs and symptoms. And when you can recognize them, you can keep yourself, your colleagues, and your patients safe, and at the same time fulfill that critical role that you play in the public health sector. So we've gotten a lot of interest since we released this webinar, and it's because infectious disease is on everyone's mind. It is a hot topic, and it's very good to see that it's a hot topic because infectious disease should always be a hot topic. But there are a lot of health center needs that are related to infectious disease prevention that health centers around the country have contacted me and said, we want to know this, we want to know this, we want to know that. There's a lot of asks because there's a lot of need. And what I'll say is today, we are going to focus on the what you need to know and the how to use it. Specifically, when I'm looking at what I know about infectious disease prevention, treating, and what I know about the public health infrastructure and what the various staff members need to know to keep themselves and their patients safe. What they need to know and what matters is, one, know the bugs, know them, know what they look like, know what they look like under the microscope in the patient. Know that picture, like when someone puts a picture of the Sistine Chapel in front of you. If I put a picture of Sistine Chapel in front of people all over the world, they recognize it because it's an iconic thing. And I want those Koplik spots and those clinical symptoms, those fevers and chills, to be like pieces of art for you so that when you see it, you know it. So when you know it, you can ask the patient the right questions. And when you know it, you can inform the public and your colleagues so that safety can be promoted. Many of these infectious diseases are incredibly, incredibly transmissible. So what you need to know is know the bugs, but that's also how they transmit. Know the patient. I've got to say, looking at, I've been in the field since 2006. I was a paramedic before medical school, of course, and then my internship and training in internal medicine. And I've got to say, it's the most confusing time ever to be a patient. Patients are overwhelmed by information constantly about health topics. And the role of the clinical provider used to be informing only, really primarily informing, telling the patient what they need to know and giving them information they otherwise did not have or have access to. Now they do. And patients come into the exam room knowing things about infectious disease, and they expect to have a conversation with someone akin to a consultant. This is particularly true with vaccination. The way I talk about vaccination has changed a lot during the years. And I will say the older style method was more of a command and control. Here's the list of things, take them, have a nice day. Parents are more informed now and want to have a conversation about each one of those vaccines. Each one of them. They want to know about risk. They want to know about risk of the infection, risk to the vaccine if there is one. They want to have conversations about their medical history to see if a vaccine is a risk for them. And even if there is not a risk, and more importantly, when there is a risk, you need to be able to have that conversation with the patient. So there's a lot of very bread and butter clinical science here with how we talk to people. We encourage folks to do better. A doctor, a nurse, a community health worker is not a commandant. They are there to support the patient, inform them, and allow them to flower. When you take that approach with discussing infectious disease and discussing vaccination, you have a higher rate of success, and that's just the science. And I will say, in general, they're much more delightful conversations. People want to be informed, and when you listen and educate judiciously, people bring that information in and they consider it. And that's where you get good clinical decision making and good partnership with patients. Partnership is the key word here. And I just want to take a look at who we have here. Oh, lovely. We have some behavioral health folks, some nurses, health department folks, the right people. Thank you so much for your service. Now, I'm going to tell you a little bit about my exposure to infectious diseases, transmittable infectious diseases, and some of the things I've learned about them. In medical school and residency, I ran a large public health system in Haiti. Jamoke actually got her start. Wave to the crowd, Jamoke. She got her start as a public health field worker in Haiti herself, so she's going to be able to give me some info here too. So, and I think it's very relatable. We had very specific infectious diseases that we had a lot of experience with. The cholera, the MMR, bacterial infections, and HIV/AIDS were exceptionally common in these communities we worked in. And what I see now as a physician in the United States, that many of these conditions that were very prevalent in Haiti at the time and are now are beginning to be prevalent in the United States as well, because people are just moving more. We have a globalized world. Things like MMR and HIV/AIDS, these are conditions where vaccination is readily available in the United States and antiretrovirals are readily available in the United States. That is not the case in Haiti. And let me tell you, I've seen these conditions at their worst. The Kaposi sarcoma, the Koplik spots, I've seen them myself, and I can see how a condition like that doesn't just affect a family, but it reflects a whole community. So just to say that, to get across just how important prevention is, because something that we have that Haiti does not have is a functioning public health system, and a big part of that is you people here today. Now, another problem we had in Haiti that I've found that I have in the United States, in Europe, everywhere I have seen patients, is the issue of patient education. It's everywhere. The question, by everywhere, I mean everywhere. Every different cultural community that you have in your health center will have a different level of knowledge about infectious disease. Your role as interpreters culturally and interpreters medically is extremely important, and being able to adapt that to the person in front of you is important as well. So next slide, please. We will go into it. And we can pass this as well. So I wanted to start with, and this is measles. Can we go to the next one? I didn't change my title there. This is measles. Now, measles is an infection that is highly transmissible, and I mean highly transmissible. If someone goes into a room and has active measles and does not cover their face and there is not a positive pressure mask on them, that measles will get into the air. Jamoke, do you know how measles gets into the air? It's so tiny. How does it get into the air? That's under an electron microscope, folks. Those are molecules you're seeing there, those pieces of purple. That's just how small this thing is. How is it getting from someone who has it to someone who doesn't across the room? Jamoke, do you have any thoughts?
It's airborne.
Airborne, what does that mean? Does it have wings? Does it fly? Audience, help her out. How is measles airborne? Chat, put it in the chat or raise your hands. I'm hearing coughing. I'm hearing coughing and sneeze. Anything else? Anything more specific? Let's build on this. A narrative. We're building a narrative. Infectious disease follows a narrative. Respiratory droplets. Okay. Whoa. Okay. Respiratory droplets. They're coming from coughing and sneezing. Why is the measles virus in those droplets in the first place? How to get there? And this is a little more about virology. What does that thing do to make more of itself? It's so tiny. Jamoke, what do you think?
Replicate.
It replicates. And where does it replicate?
RNA. Oh.
It reproduces and it stays alive. And what I'll say is, because we're getting technical, But I want to give you a picture into how this thing sees things. And of course, viruses aren't there seeing things and planning, but they follow very fundamental scientific principles that follow a narrative. And thinking about things as a narrative is a good way to remember them. And measles is a very tiny, tiny little capsid. And when that tiny, tiny little capsid comes in contact with proportionally a gigantic cell, right? We're talking a rock next to a house, right? That's a small rock in my hand next to a whole house. That's the size difference. That coating right there that you can see, that dark purple, those are proteins that are DNA encoded to be the perfect match for human cells, like a key. Opens the door. When it opens the door, that capsid that's made of different lipids and proteins, it goes right into the cell. And the middle part there, when you look in between, there's kind of a cross-shaped area. Can you see that, Jim? Okay. And you see that there's a sort of white area around it, right? The white area is fluid, and the area inside is little pieces of genetic material. That gets inside the cell, and it gets inside the cell's DNA, and the virus replicates itself through the cell's machinery. So a cell that's just minding its own business, being a skin cell or an esophageal cell or a liver cell, is taken over by the measles virus, and it stops what it's doing, and it just replicates. That means a single measles virus like that can create billions of its copies of itself. And when we're talking about something that's a respiratory droplet, well, you are active with measles. You're creating billions and billions and billions of copies of these things in the cells all over your respiratory system. Those get caught in the liquid. And so when someone coughs, sneezes, or even talks, that gets out. And now we've all been on conversations before when we've gotten a bit of a shower. Now, those are just the big ones you can feel. Every conversation you have with someone, you are being covered with back. And not to gross everyone out, but this is just science, right? We are being covered by each other, by droplets constantly. They're moving through the atmosphere, and all you need to be, that's why all you need to be is in the same room as someone. And I want you to think of that narrative and then think of that patient. Well, if someone walks into the room and they have an active measles infection, they're spraying the whole room with the thing. It's everywhere. It's on the walls. It's in front of you. It's on your fork. That's just science. These things are tiny, and they're so small, and they're so happy in water and mucosa that they will spread everywhere. So with measles, when I tell you that, and I ask you to think about prevention, prevention and spread, Jamoke, what comes to mind? What are you thinking about?
First, isolation for anyone who is already infected, to prevent them spreading.
100%. Mm-hmm. Say you're in an emergency room, or your health center runs a urgent care, and you go in and see a patient that has a pediatric patient that is covered in spots. What's the first thing that comes to mind for you? Does it have that P word that you mentioned?
Privacy.
Or the S word? Prevention and spread. Prevention and spread. Your safety as the provider is the most important thing. And when you know these conditions, and you know that when you have, say, a pediatric patient with no vaccination history who comes with a rosaceous rash, well, and I'm going to show you these things in a second, the first step you need to make is to protect yourself and your colleagues. And I can't emphasize that enough. With measles, what does that look like? That looks like a positive pressure room and full masks, full mask and gown. That's what that looks like. Now, and I'll tell you, I spent a year as an infection preventionist, and this is what I did. And what I'll tell you is every policy has different protocols. And the protocols were made very carefully, and they are unique to what your facility needs. It's also your responsibility to follow those. So make sure you know your facility's infection prevention guidelines. Know, if you have an infection preventionist, which every one of you will, know them. Know what they think the issues are at your facility. They do great things. They make antimicrobiograms. They chase cases. If you don't have an infection preventionist at your facility, know the local health department. Communicate with them. Do you have a direct email channel with your health department? Are you a health center? That's something you should prioritize. Know those people because you both see different parts of the coin. They will know what's going on from a community-based standpoint, and you will be knowing what's going on from a patient standpoint and a micro-community standpoint. You are both eyes in the awareness of that. And being able to communicate quickly when you think there is a case, which is your responsibility, to the right person is important. And them being able to inform you if, say, there is a measles case in the city or in your metropolitan area is very important as well. That communication will hone your focus, and that focus protects you and your colleagues and your patients. Next slide, please. So these are some older pictures. Great resource on the bottom left. You'll be getting these slides. This is built like a consulting document, so you guys can see all the things, show them to colleagues, and so forth. And I only use the best stuff. CDC Public Health Image Library is an incredible public resource. If you type in infectious disease, they will show you 100 different pictures of clinical pictures, what it looks like, prevention, what it looks like, and everything. So it's a great resource to have because if you have a new infectious disease in your midst, and I mean one you haven't dealt with before, throw it in there. It'll tell you what it looks like, and it's a lot easier to conquer these things when you know what they look like and you know what they do. So this here we have a pediatric patient. He's 5 years old. This is from a 1968 case. And Jamoke, we just walked into the room. I'm your attending. I've seen this patient, but I want you to see it. And I'm going to ask you some questions. Are you ready? Okay. So you do a visual inspection of the patient. What do you notice? What comes to mind first? Your observations.
The all body rash and the white on his mouth.
Okay, yeah, so those are two different things. There's an all body rash you described, and you said there's white on his mouth. There are some more. Can you see any white elsewhere in his body?
On his shoulder and chest. Oh, it's
Yeah.
on the other side. And arms.
Yeah. When you look at it, it's actually quite prominent, isn't it?
Mm-hmm.
And I'll say, look very carefully, and we're going to look very carefully at this. If you look at the rib cage on what is our right, the patient's left, you'll notice a scaling that goes across the patient's chest and follows the rib cage down. You'll also notice on the patient's abdomen that it appears brown or red in the picture. That's a reflection of the patient's skin tone, and that is rosaceous rashes. That is red, red, red. The skin is engorged with blood. Now, this is very, this is what this looks like when patients have a measles infection in its later stage. Now, in 1968, this was frequent. We'd see patients like this. And I'd like to describe those physical things for you. One, you have the scaling on the face and the mouth, and that is scaling of dry skin. When someone gets a measles infection, there's first a rosaceous rash and something called complex spots. These are painful. They are hot, 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 and the patients can be very uncomfortable, very squirmy. As the condition progresses, there is something called desquamization. And that's when that red skin gets scaly and sort of starts to shed off. And what you can see there on the chest and on the rib cage is those are skin cells that are shedding off. So if you were to touch that patient's skin, it would be rough, like a lizard almost, and some of it would come off. Now, do you think this is a comfortable situation for this patient, Jamoke?
Not at all.
How about the parents?
No.
Mm. Say this is your baby and you bring it in. How do you feel?
Worried, terrified, um, probably at your wit's end.
Mm-hmm. Mm-hmm. When you see patients like this, it's not just one patient. It's two. It's three. It depends on how many parents are in the room, and that's important to realize, not just for treatment but for prevention, because these are conversations we have. We don't direct people. We're not commandants. We educate folks. And something you need to realize is with serious infectious diseases, when you go in the room, the patient's parents are often distraught. They are terrified. And when I've seen active infections everywhere in the world, it's the same response. People are terrified. And your responsibility is to soothe, calm, and inform the patient and the patient's family in this case. Uh, Now, the same is the case when you are talking about vaccination. Um, uh, Jamoke, you just reflected on that parent who would be with the patient. Now, do you think parents imagine themselves as their child being sick one day, even if their child has never been sick? Do you think that's a fear that most parents have? It is.
Fear of,
It is.
yeah.
And I'll ask you ask it again. Do you think patients are scared of their kids getting sick?
Yes.
And trust and believe with what people see on the news, what they see on TV shows, everything they're exposed to. An image like this has been in the mind of your parents, your patient's parents before. And that's one of the things that makes infectious disease and specifically talking about vaccination so difficult. As soon as you mention vaccination, people think about something like this, or they think about it, and it's scary. It scares folks. And the important thing to do there is to inform the patient and to have a conversation. And I will say that this fear even affects people who may not want vaccines, even vehemently don't want the vaccines. The fear is still there, and addressing it is a key part to putting that conversation forward. Because when you can address the fear of infectious disease, you can address the fear of the vaccination, because it will come up in the conversation. Many patients will start it with that and say, I'm not vaccinating my children. I've made a decision not to vaccinate their children. Now, the important thing when seeing a patient like that is how you proceed with the conversation. And what I'd like to bridge is what I call respectful patient communication. Respectful patient communication. People come into your exam from everywhere, different countries, different continents. These are smart people in your communities, and they have their own perspective of the world. Vaccination falls somewhere in there. They have their own perspective of vaccination. And in order to bridge the gap, and to have a conversation with them about that, you need to meet them where they are. And that's asking them first what they think. Now, Jamoke, if I'm walking into an exam room and there's a patient that says that they've made that decision, do I just say, okay, and move on? Or do I say something?
No, say something.
What should I ask them?
Um,
A
Most likely why,
situation people
yeah,
care
why
about.
the information or what information they had that they made that decision with.
I'll start you a step back. Because remember, we are consultants. So we need to meet patients where they are to inform them. The doctor does not decide, the patient decides. With 90, I'm talking in most cases in the primary care setting, of course. Uh, I ask them first if I can have a conversation with them about it. And let me tell you, some people come into my office and they have a lot of anger about this subject. Now, I'm not going to get into why because it's not my business why. What I know is that they come in and they don't like vaccines and they come in having made a decision. And in any case in medicine, if someone has made a decision that is very important to them and you go forcefully at them, they're not going to respond well because people just don't respond well in those situations. And we need to understand that these are human beings in front of us, and we are too, and we're having a conversation. My suggestion for you is when you have a patient who does not like vaccines, ask them why. They may have a very good reason. They may have a very good reason, and you're not going to know until you ask them. And what if you talk to that patient and they let you talk to them? What does that give you? It gives you an opportunity that you wouldn't have had if you tried to hit them over the head with some facts. People don't like being condescended to. And something I can say from the feedback of my family members when I go back to Boston is sometimes I can sound condescending. And I always say it's my medical training. They taught me to talk like this. And what we need to do as physicians and behavioral health workers is to realize that some of that old system is still in us. And sometimes we dictate more than we talk. I know I'm guilty of that. And I know most of the people, and I'll say, I know thousands of clinical people, and every single one of them is guilty of it too. And it's the smart ones that know that they are. When we can be more humble about how we think about these things, we can talk better to the patients. And let me tell you, for all of the people on this webinar today, we have the incredible privilege of knowledge about the medical system, about patient care, and it is an incredible privilege. We get to serve because of that. And part of that service is communication. The best way to do it is with kindness and humility. And what I recommend is asking them if you can have that conversation. Ask them why, and address those one by one with a calm and respectful demeanor. If you do that, let me tell you, a certain percent of those people who go into the room that would not have gotten the vaccination will consider it. They might not get it this time, but remember, medicine is behavioral and it is long-term. People don't make decisions on difficult subjects right in front of us all the time. We need to give them time. And that means we need to continue the conversation in the primary care setting. We need to continue to serve those patients and to support their understanding. And when we're talking about measles, and we're talking at a time when vaccination is a more controversial subject and people have more specific needs as they identify them, you need to meet them where they are. It's just the communication gets more complicated, but we are the right people to have those conversations with them and to support those patients. Next slide, please. So this is a later stage infection. This patient would be febrile, be coughing, and if you, so same guy, right? Same kid. Jamoke, I've seen this patient already, and I'm like, I really want to show you these spots. Back one, please. I open the patient's mouth. We are, of course, fully gowned, and this is a positive pressure room, by the way. This patient is on full contact precautions. The parents have been exposed and they are on full contact precautions as well. But this is what the patient's oropharynx looks like. And medicine is a lot like art, and skin is a lot like interpreting art. Every single infectious disease physician that trained to me had an artistic eye. They really do. And it's because looking at these is about pattern recognition, just like if you were to look at a Van Gogh or you were to look at a Jackson Pollock, right? It might just look like paint thrown on a canvas until you can see the pattern. And you look in here, what pattern do you see?
Red, irritated bumps.
Yeah, that's good. Red, rosaceous, irritated. It appears irritated. Why do you think it looks irritated? Because that's something it looks like and it might feel like as well, right?
I think because it's red in color and then the raised bumps that's not flush against the skin, it would be irritating.
Yeah. So if I were to look at those bumps, and we're looking at the ones right in the middle, above the right in the smack dab in the middle, and we can see these small isolated spots. Now those spots are rosaceous. And why are they rosaceous? Why do those look red? Can anyone tell me why those little spots in the it look red? And we know this is an infection, we know that's infectious, but what made it look like that? This is important. What do you think, folks? Throw it in the chat. What is happening in those spots? Those are areas of active infection, of course. It is rosaceous, and it's rosaceous because there's a lot of blood going into that area. There's blood going to that area because the inflammatory cascade is encouraging that. The cells there are infected with measles, and they are producing those billions and billions in viral molecules. So this patient coughs, Jamoke, and a very forceful gust of air goes through their oropharynx and slides against these spots. What happens?
All of those cells that have been replicated go out with that cough.
Whoosh, out. And it goes all over the room, everywhere. So think about this. When you see things in patients like this, it means more than just a red spot. It tells you about transmission, and it tells you how that disease works. And remember, we want to get into the eye of the bug. So, and of course, this area is very irritated. The patient's going to have an excessive cough. These viruses know how to do their jobs, and they clinically encourage the inflammation cascade to manipulate our bodies and to do that. And that is what the measles virus is doing. That is what mumps and rubella are going to do as well, because they transmit in the same way. Next slide, please. So I turn the patient's back over, and we see this. I asked you to describe the pattern in front of you. Again, you are, and of course, this is me in the back. And you notice? Oh, look, what am I wearing?
A gown and gloves.
Gown and gloves. Gown and gloves. Actually, this is 1968. They're not wearing gloves, but they should be. I'm wearing gloves. This patient, what do you see? I say this patient is exhibiting this pattern, and I'd like you to identify it. Describe it.
Well, splotchy skin, more of the rosacea. And the
Mm-hmm.
splotchiness is in spots. And
Mm-hmm.
it's all back, his arms, back of his thighs. Yeah.
Yeah, look at that part in the thighs. That looks incredibly irritated, right?
Mm-hmm.
And I'll say to my nurses, teach me these things because when I go in and run from patient patient, I'm running and gunning, right? Boom, 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 boom. This is one of the things that my nurse would say that this patient it shows some clear irritation. We might want to get some cream in there to make that more comfortable for the patient. And we might want to be very careful about the positioning of the patients too. I don't want a patient that is bedbound and has this rosaceous development in their lower thighs in bed all day. I just don't want that. That's a child that is moving around in their bed and should have a clean space, and the bed, the linen should be changed very regularly. This is a patient that we need to keep as comfortable as possible because they're in a lot of pain. And the more they move, the more the skin abrades. The more the skin abrades, the more painful it is. It's a cycle. And this is the case not just of measles, mumps, and rubella. This is the case of any skin rash. Your patient comfort should really be the priority for you. So this is what this stuff looks like. Next slide. So we talked a lot about positive pressure rooms, about masking, and about safety. What's your first priority? I'll ask to the audience. When you walk into any patient room, what is your first priority? Any patient room, any patient scene, any patient's house, what's your first priority in every single one of those? Assess the Anyone? Come on, chat. What's your most important thing always? I've got coffee. I can wait. Jamoke, what do you think? Scene safety, yes. I should have believed. I should have believed. Yes, 100%. Scene safety. In this case, the scene safety is the wall. It is the fortress that protects you. You can't just go willy-nilly walking into patient rooms. When you're in, and this is, I love these things are standardized. When I worked as an infectious preventionist, I would go to all the patient rooms and put these things up. Here are the contact precautions. Here are the contact precautions. Here are the gowns. Here are the things. These things are outside of patient rooms. You need to make sure that your facility is stocked for an event like this. If someone walks into your primary care clinic and they have an active measles infection, what are you going to do first when you walk into that door? You're going to do scene safety. And you're going to immediately need to gown yourself up. You are going to need to follow your facility protocols. You are going to need to put up, if you're in the hospital, in advanced care, anywhere inpatient or urgent care, emergency room, and this is health centers, you either have these facilities on your field facilities as part of your networks, or they're in your community. So you need to know. Scene safety is the first thing. First thing. Identify, isolate. Identify, isolate. And there's a very simple thing you can do to miss the most common error. Jimoke, and we're going to talk about hospitals because that's the data, but it is correlate to urgent and care and any place that has an office with rooms. What is the biggest mistake that leads to the most cases of exposure, and this is data and my personal experience of dealing with this, is not checking the door. What's on the door, Jimoke?
The doorknob that most people will touch.
Yeah, not just that. You got infected. What? It's okay. We know. But think about one more thing. I'm going to give you a piece of information. You're going to re-answer it. Sorry. This subject gets me gassed, Jimoke. That you're going into patient rooms. There is a sign when someone is on contact precautions. It is standardized to put something on the door in any place. If you're in a primary care center and someone has been identified as a positive case, and even if you need to send them to the emergency room to be seen because you don't have positive pressure rooms, what goes on the door?
Avion said the precaution sign.
Yes. It tells you what is going on in that door so you do not run into it. What if you see a patient that has a respiratory disease that is spread via droplets? Measles, mumps, rubella, COVID-19, tuberculosis. These are all conditions that require extensive positive personal protective equipment and in many cases positive pressure rooms. They need to go to the emergency room. They can't stay in your clinic for service, or in many cases they may need to be admitted. How does that patient get to the hospital? In many cases, an ambulance will come and take them. I know we're getting into the weeds here. An ambulance will come and take them. There will be specific transport for them. Call your health department. They know these things. They have the infrastructure. They're like pianists with the infrastructure. Have an action plan. If a patient with measles is seen in your clinic and you don't know until you open the door, that's going to happen. Because people, it's going to miss the intake. Someone's going to miss it. It's a real possibility. And exposure is a never event. You need to have a protocol at your facility so that when someone sees a patient with a highly infectious respiratory disease, which there are many, measles, mumps, rubella, COVID-19, tuberculosis, active tuberculosis, latent tuberculosis, your facility has protocols. Follow them, know them, follow them. Know what the equipment is, know what the signs look like when they go on the door when a patient is on contact precautions, and most importantly, look at the door. It's funny when people look at doors. I don't know why they don't put these on doorknobs. There's the idea, Jimoke. You thought of it. Contact precaution stuff's on we can code the doorknobs different colors. Someone use that idea, please. It's yours. That would be lovely, because I can tell you, as someone who has walked into many rooms he should not have walked into, that if that doorknob had a color too, I wouldn't have made that mistake. What I do now, and I do this in my house now too, before I go any door, I look straight at it. I look straight at it because I don't want to miss those contact precautions. So, words to the wise. And again, check the CDC Public Health Image Library. It really is incredible. Next slide. Slide, please. Okay, situation time. Now I'm going to say I got these situations for everyone, and I want to for you to just answer on your toes. Let's be honest. Anyone, when you deal with these things, you're never 100% prepared. Even if everything is lined up to you, you've got all the protocols followed, it's perfect. You won't be prepared because not everyone has the experience. You're not really prepared until you've seen the stuff in front of you. And we're all going to be in the situation where we're learning. Every time you run into a patient with a highly contagious infectious disease, you're learning on the fly because it's a challenging situation. It's challenging. Jim, okay, I'm going to say this to you, and I'm in the crowd, and if no one answers, it's yours, but I would love to listen to our colleagues. Put your own hats on. What would you do? A 12-year-old patient is seen by a mental health professional in the home visit setting. Lovely. The staff member discovers the patient was recently exposed to another child with an active measles infection. And I mean exposed, touching the body, hugging, holding, and that was within the last 48 hours. Important context. You walk into this house. What are your next steps? To a certain degree, there are many right answers here. Pull the trigger, folks. Put yourself in this situation. What do you do? What are your priorities? I'm going to pull the chat. I'm excited. Come on, guys. We're all going to be in this situation eventually. In your personal life, clinical life, or something, you all will be in this eventually. Exposure. What are your priorities? I'm thinking of a comment we had recently from a colleague in our chat. Yeah, that's it. Mm-hmm. Do we have health department people here? I saw some health department people here. I would love to hear a perspective if you would be so kind as to raise your hand. Jamoki, do we have anyone? Health department people? Anyone who deals with contact? What do you like to know?
There's Angela from the Mobile County Health Department. Would you like to mute?
Can you hear me?
Yes.
Yes, ma'am. Thank you
Okay.
so much for joining us. Could you tell us who you serve and how you serve them?
I am I work here at the Mobile County Health Department, and and mainly I'm in the clinics settings, in the pediatric department for the most part. And we have a plan set up for in case if we encounter anyone with measles. We hadn't encountered that yet, that we're aware of. We are, we got everybody fit tested for respiratory masks in N95. The clerks at the desk. Um, and we're just going day by day trying to figure this out in case when it happens.
Oh yeah. You're taking the right steps. When you said fit tested, I went, yay. First of all, I don't like those masks because they make you shave your beard. I don't like that. I hate them, but they save lives, folks, including mine
Yes,
many times. And when you say you're figuring it out, what I hear is you're identifying risks and you're
yes,
intervening.
yes,
Because when you everyone fit, when you got everyone fit for those masks, you intervened and you prevented a disaster situation.
Yes. Yes. We haven't had any cases, and even in Alabama, they said they won't have any cases, but it probably might come to us. So, so we got to get ready.
Yeah, and I'll give you an analogy. Um, my mother's never been in a car accident before. I don't know how. And she drives all the time. And this is in Massachusetts. They drive up there. It scares me when I go back. Be careful. Those roads are just, they're tricky. My mother, Sonia, nope, never gotten in an accident. She'll tell everyone. So you know what I did, Jamoke? I took out her airbags and I took the seatbelts out because well, she doesn't need it, right? Did I make the right choice? No, no, she's going to need it. Just because it hasn't happened doesn't mean it's not going to. What I will encourage you with, Angela, is, and I wrote this down. Let me see. So it's important to see the eyes through the bug and the patient. And the places where that overlaps, that's where you intervene. Now, you
Mm,
mentioned the pressure masks. That's where the patient and the bug, and in this case, the staff, intervene at the same place. That's a point of contact. That's a point of
yes.
contact. What I would encourage you to also explore is a little more technical, but I think is really important to consider. Is do you have a local emergency room, or what are your communications with the local emergency rooms or larger health facilities? Do you have any channels open with them?
Yes, we do. And so we've got it set up that any of our patients, if we encounter that, they can go to the emergency room. But for the most part, um, we're not crazy about them going to emergency room unless they're really, really sick. Because we want to, if they're okay, if we can encounter anybody with measles or anything, we're not going to encourage them to go to the hospital or anything. We want to isolate them as much as possible. So the plan is, unless they really, really have some emergency, is when we'll contact hospital per se. But
Mhm.
we've got, you know, PPE equipment ready when we need it. We have a room that we're gonna put them in if we figure that that's what's going on with them. Isolate them separate from the patients. Um, we've got all our employees here. We made sure everybody's updated with the MMR vaccines, um, and titers if they can't prove they got MMR, and we double checked that this year on all the employees as well.
You know, that's very smart. I'll tell you from personal experience. I got that tested when I was first started residency, and mine wasn't active anymore.
Mm,
If I was exposed that year, if they hadn't checked that, I would have been exposed.
mm. We
That's a,
noticed
when
that
you do that.
we noticed that the mumps don't stay as long. Measles seem to be pretty good about it, but the mumps seems to can go away with some people 10, 15 years after receiving it sometimes on some people.
Well, that's interesting. That's interesting. Mm. It really emphasizes the importance of checking these things.
Hmm.
Imagine if you and someone got exposed and they've got a family, they've got a community. Whoa, that's a big issue that it turns into.
Yes.
The small issue turns into a big issue. And what I'll say is, guess who the news is going to write about? It doesn't matter if you made the right choice or not. You're in the newspaper. You're famous now. It's always good to look as good as possible in an emergency. And when you have these protocols, you set yourself up for success in difficult situations. If I may make a couple of recommendations. Now, you said
Great.
something, except in a very serious situation, the patient would stay in the clinic and you would isolate them there. That is correct. That is correct and responsible. So I commend you for saying that. And what I would say is there are and you've identified this. Yes, there are situations where that patient would need to go to the emergency room. Those are the ones I've seen. I know those patients the best. And the things that should tell you when a patient, and this should be in the protocol if you really want to get it, I would strongly recommend it in the protocol and the
Okay.
training. When do you send someone to the hospital? And the
Okay.
things that I tell clinical providers is the vitals, the blood pressure in particular, the heart rate. Is that
Okay.
above guidelines? Whoop, send them out.
Okay.
Clinical decisions, of course. Your clinical providers will know, and they
Yeah.
will know better than I. And the airway. A lot of these
Yes.
infections cause occlusion of the airway, and
Mm,
patients
yes.
with measles who also has asthma. It's
Mm,
not a good it's not a good situation. So when you are even a little bit worried about the patient's air, you got to have a really itchy trigger finger with this one. When you're
okay.
worried about the patient's airway, send him to the emergency room immediately. Call the ambulance,
Yes.
because let me tell you, it's a nightmare situation if you wait on that. I've seen many clinics who, just for one reason or another, got a really difficult patient, and if they had pulled the trigger quicker, they wouldn't have had to deal with it there.
Mm,
So a disaster situation, that's always a risk. And when your providers know to really look at that airway, and the airway to be the priority, they'll be able to assess the patient quick and get them out there. And what I'll also say is, sounds like you're running an incredible program there, and you guys are thinking creatively and responsibly about that. So thank you for sharing
thank
and for doing.
you. Thank you for the updates.
Next slide, please, Jamoke. I'm gonna go. I knew this was gonna happen. Malaria. Listen, I've had this disease twice. It's a real killer. And I had it 3 times. And you know why I had malaria 3 times, Jamoke? Because I didn't take my prophylaxis, because it hurt my stomach and gave me nightmares. Take your prophylaxis, folks. Are you going to the Dominican Republic? That's lovely. Take your prophylaxis. Search the country where you are going. CDC has specific vaccines you need to go to, and go to a travel clinic. And tell your staff too. Malaria might not be transmissible in the United States, but it is in other places. So you will be seeing that, and you will be seeing patients who have it. Big, beautiful country with people all over the world, folks. And a lot of those countries that people hail from have a tropical environment and this infection. I'm talking West Africa, I'm talking Southeast Asia, Caribbean, South America, active endemic malaria. And it's not here in the United States anymore because we catch it and we control the mosquitoes. That's not the case in most of the world. We're very privileged to have that here. The spiking fevers, up and down, let me tell you, they're a nightmare. The joint pain, it's a nightmare. Make sure your patients, when they are leaving to a vacation, and they take their prophylaxis, and look at those maps yourself, because you may not think, oh, no, Dominican Republic, that's nice, or oh, Peru, that's lovely. Good. People are going on vacations. Everywhere someone goes, there's risks, and you need to take those seriously and talk to the patients when they travel. Plain and simple. It's often a lovely conversation too. You can get a lot of travel tips that way, I promise, because they'll tell you about it when they get home, and you always know where to go. Next slide. This is what this stuff looks like. Essentially, it parasitizes a white blood cell. It's a plasmodium, a multicellular organism. It is not a bacteria, virus. It is a living thing. Next, the viruses aren't. That's controversial, actually. I'm not going to get into it. We'll save this case study for folks to look over themselves. Next slide. Just want to get these bugs. Take a look at this report, guys. Antibiotic resistance is a major issue. And I'll tell you, what I can tell you is I was an infection preventionist for a large company on the east coast of the United States. And our care homes, if we had one of them in particular that had more antibiotic and antifungal resistant infections, skin infections, than the whole countries of France, Holland, Belgium, and the Netherlands put together. I put the numbers together to try to make the points to people that this was very important. The reason we have those infections is we use antibiotics a lot in this country. And the issue with those infections is people in long-term care, in particular, are a very high risk. And if you have antibiotic-resistant Staph aureus on your skin constantly, they are colonized with it. If you get a cut, that's going to get in there. There's a chance of it. And when you get that infection, the only thing you can kill it with is fire, folks. There aren't a lot of options besides just supporting people clinically. What I would say is the thing you need to know as people in primary care clinics is that when you have someone coming from long-term care, coming from a nursing home, coming from a vent facility, if the facility has vents, you should know about it. And where the vents facility is in your area, because that's where the infections are to come from, because those are the patients that have them. Look at that patient's medical record and identify if they have an antibiotic resistant strain. They are colonized by it. It'll be right there on the paperwork. If you don't, this will prevent you from getting that contact yourself, because those patients need to be on full physical contact precautions, not droplets, just physical. Next slide. I got a minute. Next slide. Next slide. C. diff. It's a killer. When you have patients coming from the hospital admissions, look at their paperwork. Look at it. I can't tell you how many times this has happened to me. I'm going on seeing Mrs. Johnson. It's so nice to see you. Where have you been? Oh, you were in the hospital. Oh no, you had a C. diff infection, and there I am giving her a tap on the back. Read the paperwork. Have your people at the front desk, your triage nurses, look through that paperwork. If someone had a C. diff infection and is still on precautions because of that, implement those precautions. This is infrastructure. Primary care is the neural network that keeps us all together, and it is the network that gets exposed. Thank you so much, everyone, for your service. We are going to be doing a lot more infectious disease. Please answer this survey and tell me what you want to learn. This is a big subject. I spent years doing it in my training. I want to know what you guys want to know, so we can just make it more effective and learn more together. So please send me this stuff. Email me, Jamoke, Chantel, and thank you so much to your service. You guys are the castle walls and the watchtower. It's a pleasure to be on the field with you.
Thank you so much for joining us today. These slides will be available at the end of the session, so you can go through them yourself, and we'll see you next time. Thank you.